All right, hello. Welcome. I wanted to spend a few minutes talking about the role that ALS providers have in New York City and uh, sort of what's in the bag of tricks, what's in the toolkit for ALS providers, and where ALS providers can be helpful, where they might not be helpful, and where the patient might benefit from going directly to the hospital. And then I wanted to spend just a minute or two talking about how to effectively transition care to ALS and how to um, make your care mesh with what ALS is going to do. So I'm going to share a screen here. And we're going to talk first about myself right here. So let's talk about uh, what tools ALS providers have and what they can do for your patients. So, I think the first thing we could start with is airway, right? So, um, ALS providers have more options to manage your patient's airway. So we have endotracheal tubes, right? And so that can be used on a patient who's in cardiac arrest as well as a patient who is breathing. And um, we're able to secure their airway, so we'll be able to protect the airway from the patient potentially vomiting or bleeding down into their trachea and into their lungs. And we're also able to provide, so that's a positive airway, and it's also it's a better way to provide positive pressure ventilation into those lungs. So if you have patients who maybe have an issue with gas diffusion across the membrane in their lungs, so somebody with acute pulmonary edema, for example, where you have water building up along the pulmonary membrane, then positive pressure ventilation is going to enable gas exchange to occur more effectively across that membrane. So that can be helpful. Um, it also, of course, is an easier way, a more foolproof way of ventilating patients who have disordered controlled breathing, right? Patients who are overdosed or patients who have a head injury and aren't protecting their own airway or breathing effectively on their own, uh, rather than having to hold the BVM mask seal and squeeze the bag simultaneously. Now all you have to do is just squeeze that bag. So there's some pros to endotracheal intubation. Um, some of the other ALS airway modalities we have, CPAP, of course, has been added to our armamentarium as BLS providers. So, ALS providers also have that skill, but so do BLS providers. So, really, there's not, if you need to CPAP a patient, it's not necessarily on its own a reason to call for paramedics. We also have so these supraglottic airway devices. So that's the King LT, Combi Tube, and soon, of course, we'll be adding to our skill set as BLS providers the iGEM, right? And so the key thing with these devices is they're blind airway insertion devices, and they can only be used on patients in arrest. Patient must be in arrest. Uh, so if you're thinking about calling ALS for a supraglottic airway, just know that the only time ALS is going to be able to use that airway is if the patient's in arrest. So you're going to have to call them for the arrest anyway. So not really a reason on its own to be reaching out for their help. Okay, so then something else that ALS has some skills for would be respiratory emergencies. So um, again, there's many situations where we have the same tools as ALS. So one situation here is lower airway obstruction, and that's asthma, bronchitis, bronchiolitis, emphysema, COPD. all of these sort of lower airway obstructive pathologies. And so ALS have the most important drug for these patients to get if they are in imminent respiratory arrest, and that's epinephrine. But so too do we as BLS providers. So epi, not a reason to call ALS in and of itself, but probably any patient who's getting epi is going to be likely to benefit from the other skills that ALS can bring to bear on these patients, and that's going to be corticosteroids, and that's going to be magnesium. So when we think about asthma, and we can come over here and we can talk about asthma a little bit, asthma is classically thought of as being a triad. It's the much less cool version of the nuclear triad, the asthma triad. And so when we talk about the asthma triad, we think of bronchoconstriction, we think of increased bronchial edema, and then we also have increased mucus production. So as we think about those three things that make up the asthma triad, our different treatments are going to be targeting different parts of that triad. So our epi and our albuterol are going to target our bronchoconstriction piece. Our steroids as ALS providers are targeting the edema piece, so the swelling piece. Steroids bring down swelling. That's just what they do as a drug family. And then in terms of the mucus production, as BLS providers, we're actually already addressing that to a great degree with our ipratropium. Ipratropium is aimed at decreasing mucus production. And so as a BLS provider, you're already sort of dealing with that arm of the asthma triad. But the steroids are going to come in, again, to target that edema. Your magnesium as an ALS provider, this goes in IV, and that's a smooth muscle relaxant. So it's going to target the bronchoconstriction component of asthma. And as we give that magnesium, hopefully it's going to relax those muscles of the lower airway and allow for greater gas exchange to occur. So, a patient who's sick enough to get epi is also going to benefit from these other two treatments. And so for that reason, you should be reaching out to ALS for those tight asthmatic patients. But certainly don't delay administration of epi, albuterol, and ipratropium to those patients. And remember that you can also CPAP them as well if needed. Okay, so then another respiratory pathology that paramedics are well suited to treat is acute pulmonary edema. And so with acute pulmonary edema, the mainstay of treatment, the most important treatment is going to be CPAP, which of course we also have as BLS providers. But then as ALS, we have some other tricks in the bag of tricks. We've got nitroglycerin. So nitroglycerin is going to help these patients out by lowering their blood pressure and reducing the amount of fluid overload. Acute pulmonary edema patients benefit hugely from nitroglycerin, and that is not something that we're carrying at the BLS level. So definitely, if you're suspecting your patient has acute pulmonary edema, be calling for ALS to get that nitro on board. Something else that we have is Lasix or furosemide. And so Lasix increases our vasodilation, and it increases our fluid loss through the kidneys. So it helps to relieve that fluid overload for our acute pulmonary edema patients. It does take a little bit of a longer while to act, so it's not an immediate life-saving drug in the field, but it can help their hospital course go a little bit better, and so they can benefit from that. And then the other thing that ALS has for these patients is morphine and benzos. So benzodiazepines are midazolam, diazepam, and lorazepam, Valium, Versed, and Ativan. And these are anti-anxiety drugs. Morphine is a pain reliever that also has some anxiolytic or anti-anxiety properties. And so these patients benefit from those drugs because often they're having trouble breathing, they're getting anxious, and that anxiety will raise their blood pressure. And so when we give these drugs to these patients, that can help A, make them less anxious, which is just a good thing in general, but then B, because they'll be less anxious, that will lower their blood pressure and reduce the extent of the fluid overload and actually makes them better clinically as well. So for acute pulmonary edema, ALS has quite a bit of tools to bring to bear. Um, the other thing to mention just with respiratory is, of course, it ties in directly to airway, right? So a patient with a patient who is struggling to breathe may need airway control, and ALS does have that tool in the toolkit. So just keep that in mind. Okay. I think the next thing we'll move into, just to follow on our sort of ABC paradigm here, is going to be circulatory emergencies. So first thing ALS can do is we can correct an arrhythmia. So if you have a patient who is in an abnormal heart rhythm, well, we may be able to correct that. It can be tricky to identify what constitutes an abnormal heart rhythm as a BLS provider. So some things you might think about are, first, is it less than 60 or greater than 150? If so, that's probably an arrhythmia, particularly if the patient is hypotensive. Rhythms from 100 to 150 most often are a normal physiologic response to something happening in the body. So the rhythm we often see here is we call sinus tachycardia, which is a normal but sped up heart rhythm. And so if the patient's dehydrated or in pain or anxious, then sinus tachycardia is the normal physiologic response to those states. And our role as ALS providers is just going to be to find and to treat whatever that underlying cause of the tachycardia might be. If, on the other hand, the rhythm in that 100 to 150 range is irregular, and the patient has chest pain or shortness of breath, that points to what we call atrial fibrillation with rapid ventricular response. And the heart may be getting overstressed because you have a patient whose upper chambers are quivering randomly, which is a relatively common situation in older patients. And the ventricles, the lower chambers, are beating too often in response to the quivering in the upper chambers. And so for certain of those patients, particularly patients with chest pain or shortness of breath, we are able as ALS providers to give some medications to slow down the heart rate and relieve the chest pain. That which leads me to my next point, which is that anybody with suspected cardiac chest pain should get a call to ALS so that we can do a 12-lead EKG and evaluate what's happening in our heart. There's not all chest pain is cardiac, right? And not all cardiac patients present with chest pain. So I think have a broad definition of what would constitute cardiac symptoms, and also be thoughtful about the history of present illness in your physical exam findings and the assessment findings on a patient who's complaining of chest pain, right? Somebody who was just punched in the chest is going to have chest pain. That does not mean that they're having an MI. But certainly if you suspect an MI, then you should be calling for ALS. The other thing I should say is that no one who should be getting a call to ALS for suspected chest pain who should not also be getting aspirin, right? Your job as a BLS provider is to initiate care. And so if you think that this is suspected cardiac chest pain, let me let you know in secret. The 12 lead EKG that your paramedics are going to do can't rule out a heart attack. It can rule out a particular pattern that some patients with heart attacks have, which is STEMI, ST elevation myocardial infarction, but not all heart attacks are STEMIs. In fact, not all even emergent heart attacks are STEMIs. And so just because your patient has a normal EKG does not mean they're not having a heart attack. And so the idea of calling for ALS to rule out that a coronary event is occurring is a misnomer. That's not something that ALS can do. That can really only be done in the hospital with serial blood draws, looking for cardiac enzymes spilling into the blood. That's the only way that we can definitively say that a patient does not have an infarction or occlusion somewhere in their heart. So we shouldn't be calling ALS to rule out a coronary event. We should be calling ALS when we suspect that a coronary event is occurring so that we can look for the particular EKG patterns that would warrant going directly to a cath lab, and so that ALS can potentially do some other things to improve the patient experience for these patients. On that point, though, let me just say that the only drug that is given pre-hospitally that has been conclusively shown to improve the outcomes of patients who have a heart attack is the one that we give, aspirin. So nitroglycerin, which ALS carries, does not improve outcomes for patients who have heart attack. It does not lead to less death. It does not reduce the size of the injury. It does not yield increased function following the event. It does not decrease the length of hospital stay. Any of the factors that we look at to evaluate whether a drug has a beneficial effect do not show a benefit from nitroglycerin. Why do we give it? We give it for pain control. Right? That's the role, is pain is bad, and we give it to control pain, but it doesn't improve outcomes in patients with MI. So the most important things to do for these patients are, one, early aspirin, two, rapid transport to a coronary reperfusion capable facility. What all that means, the upshot of all of that, is that if ALS is more than a few minutes out, and you're relatively close to the hospital, go to the hospital. Especially if it's a PCI center, go to the hospital, and that way the patient will get to PCI faster. There is a big involved process that paramedics have to go through to bring suspected heart attack patients to a cath lab. It's time consuming, and if you're close to the hospital, just go and forget about the paramedics. You don't have to wait for paramedics if you think your patient is having a heart attack. The most important things are aspirin and getting them to the cath lab as quickly as possible. On that point, something else that you might think about giving these patients is oxygen. If they're not hypoxemic, don't do it. There is no clinical benefit to oxygen for heart attack patients. In fact, if you give them high concentration oxygen, you will vasoconstrict their coronary arteries and make the problem worse. Huge misconception out there that we should be blasting everybody who has chest pain with oxygen. It is not true. So definitely treat hypoxia, right? We have pulse oximeters. If the patient's hypoxic, that's bad. Treat it. But if the patient is normoxemic, they don't benefit from oxygen. AHA wants us to titrate our oxygen to be between 90 and 98% SpO2. They don't want it at 99, they don't want it at 100, and the reason they don't is because oxygen at high concentrations acts as a free radical and damages cells. It also causes vasoconstriction and can make an occlusive coronary event worse. All right. That's what I'm going to say about. Oh, you know what? No, one more thing. Something else, some other time when your patient would potentially benefit from ALS care is just all cause hypotension, right? All cause hypotension. We can do fluids. We can also do vasopressors to raise the patient's blood pressure. Something I like to ask people is what's more dangerous? What's worse, a low blood pressure or a high blood pressure? And I hope as an EMT, you recognize that the answer is a low blood pressure. Low blood pressure can kill you immediately. A high blood pressure kills you years down the road. So low blood pressure. So we can do fluids. We can do vasopressors. We also have other drugs that are called inopressors that raise the blood pressure as well. And so if you have a patient who is hypotensive for any reason, then by all means call for ALS. When should you not call? If the blood pressure is high, do not call us to manage a patient who is hypertensive. There's nothing we can do. Take them to the hospital. Yes, a hypertensive crisis can be an emergency, but as a paramedic, there's nothing I can do in the field to address it. Keep the patient calm, lower the lights, keep them cool, and boogie them over to the hospital. Okay. Let's talk about some of the other tools that we have as ALS providers. So, I think one category is for patients who just don't feel good. Right. So we've got anxiolytics. So for patients who are super anxious, we are able to it's super anxious and acting up, right? We're able to calm them down with anxiolytics. If they're just anxious and they're not bothering anybody, we're not able to do anything. We're not able to just give them an anxiolytic just to make them feel better. But somebody who's super anxious and acting up, we're able to calm them down with anxiolytics. Patients who are in pain, we have analgesics. We have opiate analgesics. We have non-opiate analgesics. We have IV Tylenol. We have IV ketorolac. We have IV morphine. We have fentanyl. All of these things are drugs that will help relieve pain. We also have antiemetics. So for patients who are vomiting a lot, we have a drug called ondansetron, which is Zofran, and we're able to give those patients medication to help with their nausea. So if you have a patient who you think would benefit from one of these treatment modalities, by all means, call for ALS. Okay. Let's talk about neurologic emergencies. Come down here, talk about our neurologic emergencies. So one very clear-cut time to call for ALS is if your patient is seizing. Right? We have our anti-anxiety medications, our anxiolytics are also anti-seizure medications. They're anticonvulsants. So that's one of our main roles as ALS providers is to give an anticonvulsant. We can also, for patients that are hypoglycemic and not protecting their airway, we can give IV sugar to raise their blood sugar. As well, if they're hyperglycemic, That can be just as dangerous of a situation. And so we can do, for those patients, IV fluids, which will help to address the dehydration that comes with hyperglycemia and will help to dilute the concentration of the sugar in the blood. That's an important first step in taking care of those patients. Let's talk stroke. Let's talk stroke. So stroke patients, I think there's a sense that they're very sick, and it's true they are. They're having a very serious medical emergency, but you have to ask yourself, again, what can ALS do for these patients? And the answer is really not much. So unless your stroke patient also has an airway problem, there's nothing, or an airway problem or an arrhythmia, there's nothing as an ALS provider that I can do, right? If your stroke patient is seizing, they're not a stroke patient, they're a seizure patient. If your stroke patient has an airway problem, then I can intubate them. But if they're just having a stroke, you need to just take that person to the hospital, to the stroke center as quickly as you can. You're just wasting time calling for ALS at that point. The greatest benefit to that patient is rapid transport to the hospital. Okay. So stroke, I think of as analogous to MI, right? Where if you have a patient with an MI, again, there's very little benefit that ALS care has. Definitive care is aspirin and then the cath lab. So okay. Another category that we might talk about is poisoning. So opiate overdose, you're carrying the antidote, Narcan. ALS has it as well, but so do you. So you really shouldn't be calling ALS just for a suspected opiate overdose unless you think something else is going on, unless you think you're going to need advanced therapy management or you think the patient's at risk of cardiac arrest. Uh, organophosphate poisoning. ALS does have some medications to handle organophosphate poisoning. So these are things like fertilizers. This is not something you're likely to see in New York City, but if somebody's been exposed to fertilizer and they're experiencing the sludgium group of symptoms, then ALS is able to treat that. And then the other thing is cyanide exposure. You have somebody exposed to smoke in an interior burning building, then ALS is able to treat cyanide poisoning with the antidotes. And those antidotes are quite important to get on board as quickly as possible. So certainly that would be a reason to call for ALS as well. What's the antidote to carbon monoxide? It is oxygen, high concentration oxygen. So you have that. So if you don't have somebody who is exposed to burning plastics, but instead you simply have somebody who you suspect is experiencing CO poisoning, give them high concentration of oxygen and take them directly to the hospital, probably a hyperbaric center. I think the fire department would like us to call for ALS, but again, not a ton that ALS can do for carbon monoxide patients unless they have other symptoms like hypotension or issue controlling their airway. So on that note of sort of the burn patients, a burn patient with severe burns may fall into the don't feel good category and need some analgesics. So that may be a reason to call. They may also need airway control. If you have somebody with airway burns, that's a reason to call for ALS. That airway can become rapidly swollen shut. So we need to get them intubated as soon as possible, even if they seem fine, if they're at all hoarse, if there's any evidence of airway burns, they need to get sedated and intubated immediately. So that's one situation where you definitely want to call for ALS. Okay. Just thinking through the other protocols that we have here as paramedics. Obviously, cardiac arrest warrants a call to ALS, of course. Goes without saying, but we'll say it anyway. And the other thing is if you're just not sure, right? If you feel like you're out of your depth, and you are not sure what's going on with a particular patient, then ALS is there as a resource for you. But that's sort of an overview of, I think, the broad 50,000-foot view of what it is that paramedics are able to do for your patient. So let's now take a second and come over and just talk about, as a paramedic, if I'm coming onto the scene, what I'd like to hear you give me to so that I understand what's going on. So the in-hospital tool that we use for this is called SBAR, and I'm going to suggest that you can use that as a basis for thinking about how to formulate your briefing to the paramedics. So SBAR. So S stands for situation. So that's what's going on, right? So situation might be, this is a 56-year-old male patient who has chest pain. The background is the B. So this is important information that I need to know, that's contributed, that's sort of explaining what's going on. So it's going further into the history of this event. So you might say, for background, the chest pain began about 2 hours ago as he was sitting on the sofa watching TV, and it's been getting progressively worse for that 2 hours. He took his prescribed nitroglycerin, and it hasn't helped. And he says it's the worst pain he's ever felt. The A in SBAR is assessment. So this is not your physical exam findings. What this is what you believe is going on. It is your assessment of the situation, right? So the way I might frame this for the hypothetical call that we've been talking about is, we're concerned that this is potential cardiac chest pain. I might also take this opportunity to share some vital signs, particularly if those vital signs were pertinent. So if he was bradycardic, I would take this opportunity to point that out. If he was hypotensive, I would take this opportunity to point that out. But the assessment piece is what you think is going on, and then the R is the recommendation. And of course, we have some fragile egos in EMS, so you want to be careful about this as an EMT addressing a paramedic. But what you might think about the R as is sort of the reason that you called for the paramedics. So how would I say that to the paramedics? I would say, we're concerned this is cardiac related chest pain, and we were hoping that you could do a 12 lead and evaluate for a STEMI, right? So if we were to put that all together, the way it would sound would be, hey guys, this is a 56-year-old male. He is complaining of some chest pain today. So The background is that this started about 2 hours ago while he was watching TV on the sofa. He does have a history of angina, and he did take his nitroglycerin, but it did not help. He's now complaining of 10 out of 10 chest pain. It's just gotten worse with time. He's also complaining of some shortness of breath. So we're concerned, of course, that it's cardiac-related chest pain. His vitals have been stable, nothing remarkable with those. He's satting 95 on room air, so per current AHA guidelines, we haven't given him any oxygen, but we did give him the 325 of aspirin. And we've called you because we're hoping you can do a 12 lead and evaluate for a possible STEMI and direct cath lab referral. We checked your ETA and it was closer than ours to the hospital, so that's why we've brought you here. So do you have any questions? If not, what can I do to help you out? And so that's how I think a pretty good presentation to paramedics would go. Guys, that's what I had for you. I hope this has been helpful. I hope it's been able to give you a little bit of insight into how paramedics think and what we're able to do. And I'm really looking forward to hearing what you thought. And if you had any questions for me on this, I'm looking forward to hearing you. Okay, cool. Thanks.